This is Talking Heads. Explore the latest in research and policy about serious mental health disorders with Dr. Noosha Niv.
Hi, I'm Dr. Noosha Niv, and today's guest is Dr. Alicia Lucksted. Dr. Lucksted is a clinical community psychologist and mental health researcher at the University of Maryland Medical School and the Veterans Administration VISN 5 Mental Illness Research Education and Clinical Center in Baltimore, Maryland. Her work focuses on developing, testing, and making available psychosocial programs that support the mental and behavioral health recovery of adults with serious mental illness. Over the past 15 years, a main theme of her work has been the development of strategies and programs to help people navigate and reduce stigma regarding mental illness, as well as reduce the harms that stigma can cause. Welcome, Dr. Lucksted. Thank you so much for joining me today. Let's start with you. What led you to psychology, and then more specifically, the focus on psychosis?
Well, I guess just right off the bat, I wouldn't say just on psychosis, but on mental health problems and conditions that really interrupt people's lives. So serious mental illness or psychiatric disabilities. But what led me? You could say that I realized, even as a young person, that I think in systems, and particularly am oriented somehow to interpersonal systems. Like, why does that work that way? And why do people do this? And so through my education, I learned that sort of way of thinking, one way of putting it in words was that it was related to psychology. And then in the course of that, I don't really see psychosis or serious mental illnesses as like a wholly separate thing. I see it as all on a continuum, because various kinds of emotional and mental, psychological struggles that people have are not necessarily cut up in nice, neat bins or chapters or categories like is necessary to do in some of the reference books like DSM. And so it's more seeing it on a continuum. And then I end up gravitating towards the more sort of disabling, serious end of that, simply because that's where more help is needed. I mean, that's been neglected a lot of times, stigmatized a lot of times. I'm a great fan of a combination of professional help and not just and peer help, but also other kinds of, more holistic sort of three-dimensional way of looking at things. But all those come into play more when one has more serious troubles.
Absolutely. You've studied stigma a lot. So why don't we start with societal stigma? This is a word we hear all the time, but what does it actually mean?
I use it as the umbrella term for all of those messages and stereotypes and assumptions and judgments that kind of are in the fabric of a given culture or society. And of course, that varies depending on who and where, even within a particular community. But as a general umbrella term for like all of the messages, well, what are some of the common stereotypes of X? People can easily rattle off 3 or 4 or 5 or 10. And then the ways that those affect how people treat each other. And everything from, interpersonally treat each other to like policies and practices and institutionally. So to me, it's a really broad term. And when I'm trying to figure out strategies or talk with a person or an organization about how we can make things less stigmatizing, that's just like the starting point. And then we try to break it down into different pieces so that they can be kind of grab a hold of them better and think about them and also what strategies would be given a given situation. So I use that as a really broad term.
I heard you refer to societal stigma as a social pollution.
Oh, yes. That's a great metaphor. Yeah.
I really love that. Can you expand on that a little bit? Because that really stuck with me.
Oh, well, I'm glad. I think I made it up. Maybe somebody else came up with it before, but I think I made it up. The idea was that if you live in a place that the air is polluted, if you're going to try to live your life, you're going to be exposed to that because you've got to breathe. You're in that environment. And while it is not your fault, you're still left with dealing with the consequences if it affects your health. And so therefore, a prudent person will think about what their means are for trying to protect themselves from that a bit, or compensate or something. So the analogy to societal stigma is, like I said, I think I used the idea of the fabric before, but or you could say the air, that these messages and assumptions are kind of baked in everywhere, floating around like social pollution. And if you're going to exist in any part of society, you're going to be exposed to some of that. And that's why people can rattle off some of those assumptions or have these reflexive fears and reactions when they haven't even really given it much thought. Do they even know what schizophrenia means, for example? But they sure have associations to it. And so similarly, it's not your fault that those things exist, but you are left with dealing with how it affects you.
Mm-hmm.
How it, in this case, not your lungs, but your thinking and your behavior and things like that. And so lastly, it's kind of like air pollution because we're all trying to improve it, but it takes a lot and it is a long road. In many places, air quality is better than it was several decades ago because of the things that people have worked, but it's taken decades and it's still terrible in many places. So similarly, we're all trying to improve societal stigmatization, but in the meantime, we have to walk through the current social environment that we've got, and it has a lot of stigma to trip over.
So, let's play a game of myth versus fact, right? There's really common myths that immediately spring to mind about serious mental illness. I'm going to rattle off a few, and then if you could tell me what the correct answer is it true or false? Let's start with people who have mental illness can't get better.
We know that's not true. We know that many people who have various kinds of mental illnesses do get better all the time. People, even some, get better without help. So it's definitely not hopeless. And on top of that, we know that there are lots of treatments that help a lot. Everything from medications, although it can be hard to figure out the right medication for that person at the right time, at the right dose, and the right medications can be a pain, but they can be life-saving. There's a lot of very effective medications. There's a lot of very effective therapies. Finding the right professional that works with you and for you and there's a good match can also be a challenge. And that's a drag when someone is suffering. But that's because it's complicated. And then also peer support and informal supports, everything from, spirituality to exercise to having good friends. It doesn't mean that that's going to cure a mental illness, but it certainly helps in terms of getting better. So that it's absolutely not hopeless, even though I think that symptoms can sometimes feel hopeless. It's important to keep in mind that it's not, even when it feels that way.
There's hope.
Always.
The next one that, it's popped into my mind that media and movies and, really perpetuate is that people with mental illness are dangerous.
Right. Dangerous. It's so annoying because, well, first of all, just like statistics wise, people who have serious mental health problems are much more likely to be the victims of crimes than people who do not.
Yes.
Because these illnesses can make one vulnerable, have difficulty thinking, have difficulty functioning, and makes one vulnerable to being a victim. That is where the real problem lies. People with mental health problems are no more likely to commit violent crimes or be violent than anybody else, and often less so. The other thing is that stereotype plays into this big sort of like monster, lunatic sort of picture, which really is a good way to just push people away and other them, that they're scary. And that also is not true. I think because some of the symptoms and the way people act are unfamiliar, we tend to be mean to each other when we are unfamiliar and tend to be afraid. And that plays into that violent stereotype plays into that as well.
I'm so glad you brought up the point that they're more likely to be victims. And that's kind of across the board when you talk about what type of violence they can experience.
Yeah.
What about maybe not as extreme version, but the idea that people with mental illness they're unpredictable and they're unstable, so you should keep distance?
Not so much. Not true. Of course, any person can do something unexpected. And because it's unexpected, you might call me unpredictable because I give an answer you weren't expecting or something. That's true. Of course, people can sometimes be unpredictable. That's just because we're not omnipotent, But people with mental health problems are not any more volatile, any more unpredictable, any more uncontrollable than anyone else. Anybody in an acute state can do things that are unexpected. If you're especially angry, if you're especially grief-stricken, if you're especially frightened, if you're especially anything, you can do things, even especially happy. People start jumping up and down and grabbing people. That could frighten someone next to you. When people are unpredictable, it's usually an extreme emotional state. And I think what folks often forget or don't know that, for example, being psychotic is terribly frightening and disorienting. So that when a person does something unexpected, it's out of trying to figure things out of trying to protect oneself or react. And so it's out of the emotion. It's not an inherent part of the person or the illness. So I guess what I'm trying to say is there might be a moment where I am unpredictable, but that could be true of anybody.
Absolutely. Think of like coworker who gets angry, or your husband or spouse, or
Right. I mean, you might hit a nerve with someone and you didn't realize that was a nerve, and they're like, "Wow, disproportionate."
Right. Yeah, I studied attributions a lot. So one of my can I have a favorite stereotype? But the idea that mental illness is a sign of personal weakness, that if people just buck up, they could do better.
Yeah, of course, if anyone who's familiar with someone who has dealt with mental illness or other life adversities or other health conditions know that it's quite the opposite. It takes a tremendous amount of strength to cope with health conditions like that. It takes a tremendous amount of resourcefulness and determination and active coping. It really is quite the opposite. And also sometimes that's attributed to like cause, that somehow if you were stronger, you wouldn't be susceptible to depression or something. And we know that that's not any part of the cause. It has nothing to do with ego strength or personal strength of what causes any of these things.
Right. Another one that comes up is that you're lazy.
Yeah. So similarly, it's not that gets into the idea of a character weakness as opposed to like a literal strength weakness, that you're immoral or you have bad character somehow. And I think it might be helpful to keep in mind that if you look across, because you're right, what you said, I have done a number of things related to stigma or stigmatization, which is a term I like to use because it focuses on the process that we do to each other. Whereas stigma sounds like something you have or you don't have. Where stigmatization makes it clear we do this to each other. And I just think that's important. But anyway, that if you look at the ways that we vilify or stereotype people with mental illnesses and the way that we stereotype or vilify other people that we discriminate against, we being people in general, they're really similar categories. They're not that different. Anybody who is other is usually less than us. So weak character, poor morals. They're unpredictable or irresponsible. They have ill intent. They're violent or evil or going to cheat us. There's a lot of similarity in how we other people. And then we seem to tailor it to the particular thing we're othering. So the idea of weakness is a really common one.
And with that is the sense that this person actually has control over what they're doing. So they're responsible for their behavior.
Right. And that they could just pull themselves together if they wanted to. And that therefore they're to fault and to blame. And we don't have to worry so much about their well-being because they're doing it and they're to blame anyway.
Am I missing any key ones? I feel like those are the main ones. Are there other societal ones?
Variations on themes.
Okay.
One that is related, but I will just mention one more because many people have said it to me when we have a certain program that I'm part of about trying to be more resistant to internalized stigma, is that whatever the mental illness diagnosis, that those problems don't make you less intelligent. That sometimes people who are dealing with these mental illnesses themselves are like, are you sure that one's false? Because when I am symptomatic, I can't plan my day, or I can't even, read an article on the internet or something. I can't concentrate. And that I think that maybe my fill-in diagnosis here really does degrade my intelligence. And it's just not true. When people are actually measured, intelligence does not go down. But if you think about it, if someone has, say, the flu, you often can't concentrate enough to read an article, or you get mushy-headed and you can't really plan your day and focus. And so it has to do with what's going on in terms of the illness, not with someone's character again, not with their intelligence.
So all of these ideas, these thoughts exist. And how does that change people's behavior towards the person that's ill? What's the ramification of having these thoughts?
These mistaken beliefs then lead to negative feelings towards that group and members in it. So if people are volatile or violent, we think they are, then we're afraid of them. If they're dishonest or to blame, then we don't want to be around them. So these thoughts lead to feelings, and the two together lead to behavior. Like, I want to avoid those people, or I don't want them living in my neighborhood, or even worse, taking out our unhappiness about something towards someone who is not really seen as a full person. And so even to violence or institutional discrimination or exclusion. So the mistaken thoughts, the myths, lead to feelings, which can lead to behaviors and discrimination. And that can be at the person level all the way up to institutional and societal levels.
And that can really affect policy, right? Because if I have all these beliefs about a population, then I'm not going to advocate for policy that can help them.
Of course, when I say institutional, I mean, could be the policies and programs within, and that could include the entire government. So sure, whether it's appropriations of funds, do we fund mental health at the level that it needs to be? I don't think so, just like I don't think we pay public school teachers what they're worth. There's just some inherent ways that our values and our viewpoints are baked into even our monetary decisions at federal and local levels. It also can be baked into our institutions and our government in other ways, such as laws of who's allowed to get married, have custody of children, who's allowed to do certain things, what counts for a disability, things like that.
You studied internalized stigma. So can you describe the difference between internalized stigma, or you call it self-stigma, and the type of stigma we've been talking about, and give some examples?
Yeah. I like the word internalized stigma because it describes the answer to your question of what happens, but many people find that to be a rather large word. And so the word self-stigma gets used also, but some people don't like that because it could feel like you're blaming the person, for stigmatizing themselves. So, we kind of try to use both and make everyone unhappy. So internalized stigma, if you think of it, that word is like something coming into yourself. So again, to go to that air pollution model, that if you're in a place that's polluted, it's pretty hard without some pretty sophisticated filters to not have some of that get into yourself, into your lungs in particular. Some things get into your bloodstream. And there it does harm. So it does harm when it's out in the air, you can't see the mountains and your eyes hurt, but then it also can do internal harm, and people are exposed chronically even to contribute to cancer risk and respiratory problems. Okay, so then same with internalized stigma, that if you are exposed to that frequently, and especially if you also then develop or experiencing a condition that gets put in that category, you're like, wow, people with mental illnesses are all the things we've been talking about. Oh my goodness, I am now in that category. So does that mean that I have those bad things we were just talking about? And the question is, well, what happens then? And we know that sometimes when people are exposed a lot, especially from sources that they respect or rely on, and in ways that are hard for them to distance themselves from, whatever the message is, they can start to believe those things as if they're really true of themselves and start to see their experiences through that.
So they start to believe I'm lazy, this is my fault, or I'm weak.
Right. I'm worthless. I can't be trusted, whatever it is. And so once you take that into your thinking about yourself, then it's a pretty negative spiral. And one of the people who is famous for working in this area, Pat Corrigan, talks about the why try effect. It can get you in if I'm worthless, why try to get better? If everything is hopeless and I'm always going to have this disabling condition and there is no hope, then why stay alive? Why try to be responsible? Why try to suffer through figuring out what might work better so that it can have tremendously corrosive effects?
I can see how depression would come out of any of those thoughts, a hopelessness.
Right. A lot of these mental illnesses, like any chronic illness, takes a tremendous amount of strength and persistence of active coping over and over again to figure out what works for you. And so to have that determination drained away by internalized stigma, misconceptions, is really harmful to the person's recovery.
That sounds really heartbreaking.
And of course, not everybody just falls prey to that. There are ways that one can resist it. It's not somebody's fault if they've internalized it. Just like it's not your fault if you have, a cough because you lived in a place that is polluted.
You've studied veterans as well. Are there issues that come up in the veteran population around self stigma that are not seen in the general population?
Well, for the most part, I think veterans are people first. And so there's mostly similarities. I think there maybe are a few differences. It's really important to keep in mind that veterans are really varied, and even how a person thinks about being a military veteran seems to vary tremendously from person to person. Like, it's not a central identity for everybody, it's got different contours for different people. We know that women think of themselves as veterans differently than men sometimes. So, anyway, I just want to say that being a veteran is not one thing. But even given that, there's some unfortunate clashes between stigma and some sort of military socialization. For example, the idea that you're in the military, many people internalize this idea that you need to put your needs behind the group. You need to suck it up, not complain, and figure it out, and not need help. And we really like that as a culture. We really admire self-reliance in most stratas of American culture, sometimes to a little bit of an unhealthy degree. And so we have that problem. People find it shameful to ask for help, or they think that it means they're weak or something like that. And that, I think, is reinforced by some of the military values. And so that means that sometimes veterans feel like they have failed if they can't figure it out themselves, if they do feel like they need help, or they find themselves not able to fulfill whatever roles are important in their life. They feel like they failed. And that can be a negative spiral. But at the same time, you could, and I know many, many veterans and VA peer specialists and the VA clinicians try to help people turn that around and say, well, what's another value in the military, which is teamwork and getting the mission done. If you needed help putting in that engine by yourself because no one can lift 500 pounds alone, you better ask for help about how to operate the winch or whatever. You'd be stupid to not, And so to try to use values to also support people's recovery. But that self-reliance can sometimes be a problem for veterans.
That's a wonderful reframe.
I did not come up with that one. I learned that from a couple of VA clinicians.
Okay. You talked a little bit about why try, and what is the effect of stigma on treatment seeking, on outcomes? What is the impact besides it doesn't feel good?
Well, let's see. So I live in Maryland, and in the rural part of our state in Western Maryland, I've heard a number of people, I've heard this story numerous times over the years, that people will drive half an hour away from their hometown to see a therapist, because there's usually only one county health department or one or two, counseling practices. And they're pretty worried that somebody in their small town will recognize their truck or their car parked out front, and they don't want it to be known. So in addition to wasting gas and time, that's just an indicator of the answer to your question, that stigma can keep people from getting the help they deserve and would benefit from. We said at the beginning, it's not at all hopeless. There are lots of effective treatments of all sorts, and stigma can keep people from those. It can make people ambivalent about engaging. I really feel I'm desperate. I really need some help. And it's so embarrassing and so horrible. And what will people think? It can make people very ambivalent or rejecting of medication, as if that shows that they're weak, when really it's a matter of a great tool that you don't always need medication to deal with mental illnesses, but it's a good option to consider in many cases and can be tremendously helpful. And then on the other side of the coin, outside of treatment, it really blocks off a lot of opportunities that just because I have a mental illness or you do does not mean we don't deserve to have certain opportunities. And the stigma can really block off a lot of those.
Well, can you give some examples?
Like people not wanting to associate with you if they do see your car at the counseling center, or activating all of those stereotypes, or at least a bunch of them that we were just talking about, if they see your pill bottle sitting on the bathroom counter when they use your restroom and happen to know what that is, or go look it up because they're nosy, or employers wanting to know why there's that gap in someone's resume, or just not even wanting to know, just not employing people who have gaps in their resume at all.
So your ability to participate in things we do to connect with other people, it could really lead to some isolation, right? If you're not inviting people over because they might see your medicine, if you're not applying for jobs because you have a gap in your resume, that can be really isolating.
Sure. And that's an additional step. Like there's one that is opportunities blocked because people really do discriminate or exclude or reject. Why would you want to walk into a situation like that? So you start trying to anticipate where you might run into stigma and self-selecting to not engage with that, which of course on one hand makes a bit of sense.
Mm-hmm.
Why go someplace where people are going to be disrespectful to you or even dangerous? But of course, like a lot of worry, when it gets overgeneralized, it feeds into just what you were talking about, like not even applying for something because even though I really want a job and I feel bad that I don't have one, not applying for any jobs because, well, I'm afraid that all employers are like that and kind of getting overgeneralized. And so trying to walk between those two extremes of protecting yourself, yes, you got to be discerning, but not overly generalizing so that you cut off your own opportunities. Again, understandable, but not getting you closer to your goals.
Right. Especially if we think of recovery as not just symptoms, reducing symptoms, but as participating in your community and making social relationships, having a job, and these other functional outcomes.
Well, yeah, I totally agree with you. And I also think of it in terms of roles, that roles are really important for people. For example, what does it mean to be an adult? Many times it means in our cultures, supporting oneself economically and living on one's own. Now, I don't personally think that living on one's own is always better than living with other people. I mean, but we have this thing baked in that like, you need to be independent. And so when someone's not, they feel worse about themselves or they have to fight to feel okay about doing things a different way. So yes, functioning and then also roles. Am I a good neighbor? Am I a good family member? Can I even be a family member? Can I act as a family member? It's always stuck with me, a man who I was working with who said, I want to be a member of my family, not a project of my family.
Oof.
And want to be like fully a member who gives and takes and is not just seen as a recipient or a problem.
Right. Are there factors that we know increase one's sense of self-stigma?
Yeah, some of them I mentioned are environmental. It's higher risk if you're exposed repeatedly,
Okay.
especially from sources that you see as credible.
By credible, you mean a doctor or a family member, friend? Like, is it based on the relationship?
I think it's really any kind of credible. I mean, that could be like a doctor would be like an expert. Unfortunately, when there are surveys, people who have mental illnesses will mention healthcare providers as one of the top 3 or 5 sources of stigmatizing attitudes and statements. So yes, here's someone you're going to for help and they're saying or doing that thing. Very harmful. But also other kinds of credibility. Family members who you think these are people who love me and who I trust, when they're stigmatizing, it can be hard to separate the mistaken belief from the relationship and reject the belief without feeling you have to reject the relationship. Or other sort of social leaders, if you're part of some sort of faith community,
Mm-hmm.
religious leaders there, or part of certain social communities, the social leaders there, can be hard to say, well, I think they're really fabulous and there are great thought leader or something, but they're totally wrong about this and being horribly mean about it. They can be hard to hold that dissonance. And so that makes it more vulnerable. But also, do you use the term identity engulfment or diagnostic overshadowing?
What is that?
If you take on the identity of your mental illness or the diagnostic label as defining you, then you're much more susceptible to defining yourself with the stigmas or the misconceptions that are associated with that.
That makes sense.
As opposed to, like, can even come out in language of saying, I'm a schizophrenic versus I'm from Baltimore, I play the tuba, and I deal with this annoying thing called schizophrenia. Not to downplay its seriousness, because it can be very serious, but it's different to have it be part of your life than it to be what identifies you and defines you.
Because that feels all consuming to say, I am schizophrenic.
Yes, and then everything about schizophrenia is equal to you. I mean, there's not really other parts to dilute those messages.
Okay, so who the message is coming from, how often you're getting the message, that can increase your identity around your diagnosis. Anything else that can increase self-stigma?
Also, not being well informed about one's own illness or symptoms and mental illness in general, not knowing the myths from facts. Bipolar is not the same thing as split personality, or you don't know what it means to be dealing with depression or OCD or whatever. If you don't know, we are not very good in terms of general education about mental health literacy. So you can't blame someone for not knowing, but that is a danger because then you don't know to say, oh, that person clearly is ill-informed. They are not a credible source here because they're saying some pretty off-mark things if you don't have some base of knowledge. So one of the things we talk about, you can make yourself more resilient against stigma by becoming well-informed.
It's a great segue to my next question. So how can we protect against self-stigma? So education.
All right. So myth from fact.
Mm-hmm.
It's also not enough to just know something is wrong, especially if you're trying to stave off internalized stigma. It is sneaky and sticky. It's like gets in there. So it's not just enough to know that something's wrong. It's much better to do like active counter messaging for yourself. I know that this is because of my symptom. It does not mean that I am a weak individual. Some people will write a Post-it and put it on their mirror.
Like those, affirmations people do.
Yes, but particularly targeted to counteract, counter messaging.
Right.
And getting that in there is a way. The opposite of identity engulfment is to grow, and this goes right along with the sort of recovery paradigm of mental health and services, is to grow the other parts of yourself. So to think about what are your strengths, what are your values, what are things that are important to you, and deliberately fight to give them some air and sunshine and water so they grow, because that gives you more personal resources internally. And also it gives that stigma a smaller target. In terms of being exposed to sources, people can take some agency. I mean, that's another important thing, that you're not just a passive target of societal stigma and all these, messages flying around, that you can have an active stance in how you choose to deal with it. So, of course, that's not to say one just writes off all of one's family or whoever says or does something that's unkind. People are imperfect. They may be ignorant themselves. You may be reliant on them. In one of the programs that I'm part of, we talk about increase the positive, decrease the negative, and bring your best self to the interaction. For close-in interactions that are mixed, positive and negative with regard to stigma. So how can I increase the positives in that relationship? Not that I'm responsible for the person's ignorance or stigma, but just it is an interaction. So is there something I want to do that could increase the positive? One example quickly might just be thanking them for some portion of the relationship you really like. That does not mean you're forgiving everything else or forgetting everything else. Decrease the negative could be asking someone if they could stop using a certain term. And maybe they'll tell you to go jump in a lake, but maybe they'll ask you why. And listen, it might be possible. But even if they ignore you, you've stood up for yourself and articulated something. And you get some data back about where they're at or what their limitations are. And then bring your best self. If you're going to an interaction that you know is probably a bit dicey, how can you be centered and strong? I always use the example of a difficult family situation I had for years, but yet I was going there and it always made me miserable. And I found that if I brought wintergreen lifesavers, I was better. I was calmer. I know that's totally random, but I happen to like wintergreen lifesavers. And I would literally go buy some before we went to these relatives' house.
And it worked.
So it doesn't have to be a big deal. Sometimes it can be like bringing a book so that if you feel excluded, you go out on the patio and read, and you like that. It's all about what you like to do to take care of yourself or bring your best self to the interaction.
So, what if we can't get to people in time to prevent self-stigma? Let's talk about what we can do to improve the situation. When someone is already experiencing it, intervention can take place on like two levels, right? On the level of the individual and societal, which is a big issue. You have developed an intervention that addresses the individual part.
Yeah. It has a couple of variations now. So the program itself is sort of an educational and skill building program called Ending Self-Stigma that I created with several other people a handful of years ago. And it's like a class or a psychoeducational group. It's offered in a number of community programs and VA units or programs across the country, and even in a couple other countries nowadays. It doesn't have to be delivered by a licensed mental health person. It's a lot of times delivered by peers as well. Really just anyone who has a basic knowledge and is a good group facilitator. There's a pretty explicit manual that anyone can download. But what it consists of is we tried to boil down what was known from research and from clinical experience and from lived experience about being resilient in the face of internalized stigma, pushing it out of one's thinking, and package those into practical strategies. So I sometimes use the idea of mix it all up, bake it, and then slice it so that it's accessible to people. And I think underlying all of it is the fact that I ended up working in the area of internalized stigma because I think there's a lot of people trying to reduce societal stigma. But it seemed like this idea of those messages are out there and, oh my gosh, now I think I'm a member of that group. So does that mean those are all true of me? That is horrible and is another weight of dealing with these illnesses. That's just terrible. We were neglecting that as a field. And so that was a niche that we could perhaps help it. Underlying all of that is the idea of naming internalized stigma as a hazard. I think is really important. I think that mental health programs, people, self-help groups should be mentioning it like, hey, and this other thing that can happen really sucks. And you should at least know that it's a possibility or a danger. Not everybody has problems with it, but you should know it's out there. So you can watch out for it. By giving things a name, we can talk about them and problem solve them more.
Is this program available, you said, for anyone to download?
Yeah.
Okay, great. I'll put a link to that then.
Yeah, there's a rather long manual, long because it's detailed so that you don't need certification or whatever. You can literally pick it up if you have good group skills. And we're happy to consult and talk to people when they want to, but we wanted it to be like low bar. If you thought it would be useful for your center or your practice or your whatever, we wanted it to be low bar.
Mm-hmm. I'm going to switch gears. I have a couple of questions from my Facebook page.
Cool.
All right. Do the type of hallucinations or delusions someone has affect how much stigma they experience?
Wow, that's a cool question. I can imagine that it could be so. I have never had hallucinations myself, but maybe we all have delusions of some sort. But people that I knew who have said that they quickly learn to keep some of them to themselves if they can, except in the most trusting of circumstances, because they can be frightening and strange, and that can exacerbate that otherness so that they try to not show or tell some things. So I think the more that they're negative, frightening, or strange to others, they could feed into those stereotypes that you're dangerous or that you're kind of alien. But I don't know, what can you add from, your Facebook page readers more than I do?
Well, I'm just thinking like in terms of hallucinations, there's lots of different types of hallucinations, and auditory are the most common. But I think someone's reaction might be very different if you are hearing voices but not talking back to them, for example, versus you're in an argument with your voice you're hearing. So I could see how that presents to someone who doesn't know what's going on would be significantly different.
Right. And that's kind of what I meant, is that people try to not describe and not show what some of them are and learn to not respond or not respond clearly.
Right.
At the same time, in terms of positive coping, some people find that talking back to their voices can quiet them down. So they just might need to figure out how to do that and what works for them.
From a study I did on attributions, I know that family members were much more tolerant of religious delusions. Yeah. If the family was religious, they didn't actually perceive a lot of it as delusion.
And there are some that are not negative, that are neutral or even positive. And of course, there is a movement more prevalent in Europe than in the US, but there are chapters here of voice hearers that hallucinations are, not everybody considers them by themselves to be a pathological thing. I mean, it's normative in a lot of cultures, for example, to hear voices from someone who's passed away recently. Mm-hmm. I mean, so my point is simply that hallucinations are not always considered a psychiatric symptom in all cases, but some of them are even positive or neutral. So I think when they're more negative, they're also more stigmatizing.
Okay. The second question I got is, how should my daughter's therapist address the shame and stigma she's experiencing? I think we've talked about that a little bit.
Yeah. Far be it for me to tell someone what they should do with their therapist as a client or a therapist. There's so many things that one doesn't know in that simple sentence, and it seems quite improper to say. So being a little bit more general, one can think about where shame comes from. It comes from seeing or assuming judgment from others. And therefore, where is that judgment coming from? And how can we dilute it or help the person decide what they think of it. So then instead of feeling that it's legitimate and therefore I am that and it's shameful, to think of it as, oh, it's so sad that that person or that group is so ignorant, or it's so unfortunate that they can't be more compassionate, but I can try to be compassionate towards them, which again is not to say it is the target's responsibility, but that a reframe can sometimes come from a place of strength and help the person not be subject to the shame. But I can't tell someone what they should do with their therapist.
But it seems like at a baseline, this person's daughter would benefit from education about her illness.
And about the stereotypes and stigma like we've been talking about. Are there misconceptions that are baked into that chain?
Exactly. Last question for you. What are you most excited about in the field of psychosis or serious mental illness? In your case, it's your work's not psychosis specific. Like, what are you seeing as having the potential to really improve lives?
Wow. You might ask me this question 5 minutes or 5 days ago, and I might give you a different answer. But my reaction is, I think that in recent decades, there has been some progress at breaking down the lines between, or the walls between us and them, between people who have mental illnesses and people who help people who have mental illnesses, or people who study people who have mental illnesses, using that terminology deliberately because it makes it seem like, oh, I am studying you. I think there is still a lot of that, but there has been some gradual thinning or breaking down of that wall so that people who are living those illnesses are more part of the conversations. People who are the therapists, the psych rehab counselors, the researchers are gradually able to be more open about their own mental illness experiences, their own struggles. So it's less us, them. And I think that that is very promising because it means we can bring together the strengths of like scientific paradigms, the strengths of lived experience, and other things, clinical experience, qualitative research, to bear on the problems rather than having to defend against them. But I know that's kind of a meta answer. I hope you weren't thinking about something concrete.
No, I love that. It's a very broad question, looking for a broad answer. That's great. It's true. I see so much more work done with lived experience, which is needed. That voice is needed.
Yeah, and not just like, again, using these terms deliberately, including them in our research or in our stuff, but rather more mutuality in a number of different directions. And we need to push that. We don't want to be tokenizing or reifying it in a new way, but I think we're making some progress.
Well, wonderful to have you. Thank you so much for joining me today. This was such a great discussion, and I learned quite a bit from it. I really appreciate you.
Oh, well, it's a pleasure talking with you. Thanks for adding your ideas. I appreciate it.
This is Talking Heads,